Stroke. It's a word that sets off alarm bells and fills many with fear. But what exactly is a stroke? What causes it? What type of patient population is most likely to have strokes? How can we prevent strokes from happening? What are some major signs and symptoms? And how can we diagnose them? All of these questions will hopefully be answered in this video. So let's start with a clear definition of stroke. A stroke, also known as a brain attack, occurs when the blood supply to a part of the brain is cut off or severely reduced. The brain is one of the most metabolically demanding organs in the body. It constantly needs energy. Without a steady supply of oxygen and nutrients, brain cells begin to die within minutes. Once neurons die, they cannot be replaced or regenerated, so strokes often lead to irreparable brain damage. There are two major types of strokes: ischemic strokes, which account for about 80% of all brain attacks, and hemorrhagic strokes. An ischemic stroke occurs when a blood vessel supplying a part of the brain is occluded or blocked by a clot. If a blood vessel is very narrow and a clot forms in the vessel, the stroke is thrombotic. A thrombus is a blood clot that obstructs a vessel in the same place it was formed. If a thrombus forms elsewhere in the body and breaks off into the blood circulation, it's known as an embolus. When an embolus blocks a blood vessel in the brain, the stroke is embolic. Plaques formed from atherosclerosis can also form emboli and cause ischemic strokes. A third type of ischemic stroke can occur when there's a severe narrowing of an artery in the brain or neck, and this is called stenosis. A hemorrhagic stroke occurs when a cerebral vessel bursts and leaks into the brain. This is more likely to happen if the vessel is weak, such as if there's a bulge known as an aneurysm, or if the person has an arteriovenous malformation. So why are strokes such an important medical topic? Stroke is the number 4 cause of death and the leading cause of adult disability in the United States. About 795,000 Americans suffer a new or recurrent stroke every year, and that's roughly equivalent to one stroke about every 40 seconds. A stroke is a medical emergency, and like so many health crises that require urgent care, the most effective treatment is prevention. And the key to preventing stroke is reducing risk factors. These can be divided into two main categories: preventable and non-preventable risk factors. Risk factors that we can control include hypertension or high blood pressure, diabetes, high cholesterol, smoking, obesity, as well as cardiovascular diseases such as atrial fibrillation. Other risk factors are family history of stroke, age, race, and gender. So now let's take a look at some of the major risk factors a little more closely. Hypertension, which is defined as when blood pressure is greater than 120 over 80 millimeters of mercury, is the most important risk factor for preventing stroke, and key to this is that it can be managed. Medications, diet, and exercise all play an important role in controlling blood pressure and reducing the risk of stroke, especially reducing the risk of a hemorrhagic infarct. Better management of high blood pressure has been linked to a reduction in death from stroke over the past few decades. So smoking, obesity, poor diet, and high cholesterol all significantly increase the chance of cardiovascular disease. As the heart and arteries become weak, systemic circulation decreases, increasing the chance that an embolus will form and eventually travel to the brain to cause a stroke. So these three risk factors, smoking, obesity, and high cholesterol, are also heavily implicated in atherosclerosis, in which plaques can eventually break off of damaged vessels to obstruct blood flow to the brain. Decreasing the number of controllable risk factors for stroke, especially hypertension, is crucial and is the most effective way to lower the incidence of stroke. So now looking at some of these other risk factors, the most significant are age and prior history. The chance of having a stroke approximately doubles for each decade after 55. The incidence of stroke is also higher in those with a prior history or family history of strokes or mini strokes. So what are mini strokes? Transient ischemic attacks are known as mini strokes because they represent a loss of cerebral function due to temporary ischemia or lack of blood supply. TIAs have the same underlying cause of stroke, and they often manifest similarly. But the big difference between them is that the patients Patients who suffer TIAs often recover full function within minutes to 24 hours. These are important to recognize and treat because patients with prior TIAs are almost 10 times more likely to eventually suffer a stroke than someone of the same age and gender who hasn't had one. So now, what are some important signs and symptoms of stroke? When it comes to stroke, the faster you can recognize when a patient has suffered one, the faster it can be treated, and the better the outcome. The American Stroke Association uses an acronym FAST to help people recognize the most common signs of stroke. It's an easy one to remember, so let's go through it. F stands for facial drooping. Is the side of a person's face drooping or numb? A key way to see this is ask the person to smile and see if their smile is uneven. A is for arm weakness. Is one arm numb or weaker than the other? Ask the patient to close their eyes and lift both arms at shoulder level. Does one arm drift unconsciously downward? A similar technique can be used for the legs, asking the patients to lift their legs and observing if there's any downward drift. S stands for speech difficulty. Is the person having difficulty saying words clearly? Are they having trouble finding the right words? Is the patient confused or disoriented? And T stands for time to call 911. A stroke is a medical emergency. So anytime a person shows one or more of these symptoms, it's really important to get into the hospital for treatment. So some other key signs and symptoms of stroke to look for include difficulty walking, which can be due to weakness or paralysis in the legs, a sudden loss of vision or blurred vision in one or both eyes, and a sudden headache, which can often be described as the worst headache of your life. All of these symptoms, especially the headache, can also be accompanied by dizziness or loss of consciousness. So, the patient or a patient's family member calls 911. The patient is exhibiting numbness on his right side, including a right facial droop and slurred speech. They're rushed to the emergency room. So now what? How is this patient diagnosed as having a stroke? Once the patient arrives at the hospital, the neurologist on call administers a neurological test and physical examination known as the NIH stroke scale. The stroke scale is composed of 11 items, each of which scores a specific ability between the 0 and 4. The components are then added up to calculate a person's total stroke score. The higher the number, the greater the severity of the stroke. Any score between a 21 and a 42 is considered a severe stroke. The NIH stroke scale examines a number of basic abilities, such as the patient's level of consciousness, visual field, language skills, facial droop, as well as arm and leg, motor, sensory, and coordination skills. So once the stroke scale is assessed, the patient is usually taken to some kind of imaging. Computerized tomography or CT scans are used in many hospitals. These give quick results and are valuable in detecting bleeding in the brain in the case of a hemorrhagic stroke. Bleeds can be seen very early on CTs as wider, paler areas. Ischemic stroke appear as darker areas on CTs, but are harder to see in an acute situation because they often don't show up until 6 to 8 hours after the stroke has occurred. Magnetic resonance imaging, or MRIs, are much better at detecting acute ischemic strokes because the infarcts show up much quicker than on a CT. The areas of brain injury appear lighter on an MRI. Unfortunately, MRIs are not used as often as CTs because they're expensive, not available at all hours, and not an option for patients with metal implants like a pacemaker. Some other less widely used imaging that's done for the diagnosis of stroke is a carotid ultrasound to look for narrowing in the carotid arteries, a cerebral angiogram to look for a blood vessel in the brain that's blocked or bleeding, and an echocardiogram to see if the clots were formed in the heart that could have traveled to the brain. Blood tests to check for clotting time, sugar levels, and enzymatic imbalances are also performed on the patient. And that is all for this video. Thank you so much for listening, and check back for more videos on stroke pathophysiology and treatment.